Imagine sitting in a brightly lit doctor's office, right? You're staring at this modern medical chart on a sleek digital tablet.
Yeah, we've all been there.
Right. And you're reading your after-visit summary, or maybe you're checking the side effects listed for like a standard COVID-19 vaccine.
Mm-hmm.
And the terminology just looks so incredibly precise. It feels like this absolute cutting-edge science. But the diagnostic codes that are actually determining your medical care, the very words defining your pain, they're often just 17th century Greek naming accidents.
It's a remarkable illusion of precision, honestly.
It really is.
Because we look at a medical diagnosis on a screen and we just assume it functions like a mathematical formula, when in reality, we're frequently looking at a linguistic fossil.
Which is exactly what we're getting into today. Our mission for this deep dive is to execute a really thorough exploration into the fascinating and honestly surprisingly contested world of medical pain terminology.
Yeah, it's a messy world.
It really is. Specifically, we're going to look at two tiny word fragments that do a massive amount of heavy lifting in our healthcare system. The suffixes -Algia and -Dynia.
Right.
The source material you've shared covers their bizarre historical origins, the intense medical debate surrounding them, and the real-world impact they have on millions of patients today. So, okay, let's unpack this, because everyone listening has heard terms like neuralgia or fibromyalgia.
Oh, absolutely.
But almost nobody knows the secret history built into those suffixes.
Yeah, and we really have to start with the illusion created by the words themselves. If we trace these suffixes back to ancient Greek, algia comes from the word algos, which means pain.
Right.
And dynia comes from odyne, which, well, it also means pain.
So they are essentially etymological twins.
Exactly. They mean the exact same thing.
And when they were absorbed into the Latinized medical vocabulary that European physicians started using, from the 17th century onward, you'd think there was a strict clinical rule dividing them.
You really would think that.
Right. Like a natural assumption is that algia implies a sharp, acute injury, while dynia represents a chronic, dull ache or something like that.
Yeah, and that is actually the #1 misconception medical students have when they first encounter this pair.
Oh, really?
Oh, yeah. They instinctively search for the clinical rule differentiating them. But there is zero consistent rule.
Wow.
They are completely functional synonyms, the choice of which suffix to attach to a condition was made term by term. It was entirely dependent on whichever physician happened to be the first to publish a name for that specific condition.
So whatever suffix they chose just became convention.
Yep.
Whoever published first won.
So it's essentially like choosing between the words car and automobile.
It's a great way to put it.
But if they mean the exact same thing, why did medicine keep both? It's like compiling the first open source medical dictionary where whoever hits publish first locks in the terminology forever.
Yeah.
Which just seems incredibly haphazard for a scientific discipline. It is haphazard. And to understand how this happened, you have to look at what medical historians call a taxonomic accident.
A taxonomic accident.
Right. So back in 1763, a French physician named François Boissier de Sauvage de la Croix, he published this massive, ambitious work called Nosologia Methodica.
That is quite the title.
It really is.
Oh.
And he was trying to classify every single known human disease using the exact same hierarchical system that Carl Linnaeus had just used to classify plants and animals.
Oh, wow. So he was trying to build like a periodic table for human misery.
That's exactly what he was doing. We're talking about categorizing over 2,000 diseases into classes, orders, genera, and species.
That's a huge undertaking.
Huge. And what's fascinating here is the sheer scale of the naming crisis that followed. Because to give each of those thousands of diseases a precise, describable name, doctors just started snapping Greek and Latin roots together like Lego bricks.
Right.
They would name the anatomical location, attach a symptom suffix, and move on to the next one.
Just rapid fire.
Exactly. And because algia was slightly easier to pronounce in combination with other Latinized words, it just became vastly popular. It appears in dozens of everyday clinical terms.
Okay, that makes sense.
But dynia, it ended up clustering in a much smaller group of oddly specific and often historically stigmatized anatomical regions simply by historical luck of the draw.
It's wild that the resulting vocabulary tells these incredible historical stories rather than, conveying objective biological facts.
Yeah, the basic grammar of the system is deceptively simple.
Right, because you just take the body part, add the pain suffix, and boom, you have your diagnosis.
Yep, that's it.
But crucially, you have zero information about the underlying cause. Like, A diagnosis of cephalalgia sounds incredibly sophisticated,
Hmm.
but it literally just translates to head pain.
Yeah, it's purely descriptive. It names the location and the symptom and literally nothing more.
Right.
And this contrasts sharply with an inflammation suffix like itis. So a diagnosis of arthralgia notes the presence of joint pain, whereas arthritis explicitly claims the presence of inflammation, which alters the entire treatment protocol.
Because inflammation means heat, redness, swelling, things you can actually treat.
Exactly. And confusing a symptom description for a mechanistic explanation is where a lot of clinical errors happen.
Yeah, and speaking of how words drift and change, the nostalgia story is the perfect example of this. I was totally caught off guard by its origin in our sources.
It's one of the best historical anecdotes in medicine, honestly.
Tell me about it.
So in 1688, there's this 19-year-old Swiss medical student named Johannes Hofer,
19.
19, and he coined the term nostalgia in his dissertation. He combined the Greek word nostos, which means homecoming, with algos, meaning pain.
Homecoming pain.
Right, but he wasn't writing about a fleeting emotional feeling.
Well,
He was describing a lethal physical illness he was observing in Swiss mercenaries who were serving abroad.
wait, lethal.
Mm.
He documented soldiers literally dropping from profound bradycardia and soaring fevers, right?
Yeah, bradycardia, severe indigestion, loss of appetite, wasting, and in the most extreme cases, death.
It is insane.
Physicians of the era treated it as a genuine, potentially fatal medical disease. The remedies ranged from applying leeches to administering heavy doses of opium.
Wow.
And the only truly reliable cure for this disease was actually discharging the soldier and sending them back to the Alps.
Here's where it gets really interesting. Just think about how we use that word today.
It's completely different.
We use it for this wistful, faintly pleasant emotion. You look at an old photograph and you feel nostalgia. But it began as a potentially fatal medical diagnosis, sharing the exact same medical suffix as neuralgia or myalgia.
Yep.
A teenager snapped two Greek words together, and 300 years later, it's literally a marketing buzzword for rebooting old movie franchises.
It perfectly illustrates how much a word's meaning can drift over time. And that evolution exposes the fatal flaw in this entire symptom-based naming system.
How so?
Well, it describes the geography of the pain, right? It tells you where it hurts. But it never tells you the pathology. It never tells you why.
Right. I kept thinking about it like a medical IOU.
Oh, I like that.
Yeah, an Algia diagnosis is basically a placeholder. The doctor hands you a slip of paper that says, I agree that you have pain in this location, and here's an impressive Greek word to prove I acknowledge it. But this is an IOU for an actual explanation that we haven't found yet.
That's a brilliant analogy. And the thing is that IOU can remain uncached for centuries.
Centuries.
Oh, absolutely. Take a pure algia diagnosis like trigeminal neuralgia.
Okay.
It was first clearly described by an English physician named John Fothergill in 1773.
Wow.
And it affects roughly 4 to 13 people per 100,000 every year, disproportionately women and people over 50.
And from the sources, Fothergill was observing patients experiencing this sudden electric shock-like facial pain along the branches of the trigeminal nerve.
Yes.
The attacks were so severe they could be triggered by something as minor as brushing teeth or just a gentle puff of wind on the cheek.
Yeah, historically, it earned this really grim nickname of the suicide disease because the pain was so relentless and demoralizing.
That is terrifying.
It is. But look at the name, trigeminal neuralgia. It just says nerve pain in the face. It offers zero mechanism.
Right, it's just the IOU.
Exactly. But today, modern neuroimaging reveals that in most classic cases, the cause is actually an aberrant blood vessel, often the superior cerebellar artery, physically looping around and compressing the trigeminal nerve root.
So the constant pulsation of that artery is just physically wearing away the myelin sheath protecting the nerve, which causes raw electrical misfires.
Exactly.
We literally have the mechanical answer now. But the name is still just floating around as a symptom description from 1773.
If we connect this to the bigger picture, that mechanical mismatch, having a name for the pain but not the cause, that's exactly what forced the medical community into a corner in the 1970s with fibromyalgia.
Oh, fibromyalgia.
Right. This is where a deliberate name change fundamentally altered how we understand a disease. Because before 1976, fibromyalgia was widely known as fibrositis.
Ah, and the itis suffix locked doctors into expecting inflammation of the fibrous tissue.
Exactly. They were looking for something that wasn't there. Researchers, most notably a rheumatologist named P.K. Hench, pushed to rename it because repeated biopsies and laboratory studies consistently failed to find any inflammatory markers.
So there was no inflammation.
None. The tissue wasn't inflamed, but the patients were undeniably in severe widespread pain.
Right.
So swapping the itis suffix for the algia suffix was a deliberate, symptom-honest downgrade.
A downgrade.
Yeah, it was the medical establishment admitting they didn't know the mechanism and just retreating to naming the pain.
That structural admission of ignorance shifted the entire diagnostic landscape, didn't it?
It really did.
Because in 1990, the diagnosis was based on applying physical pressure to 18 specific tender points on the body.
Right, the tender point exam.
But by 2010, the rheumatology community realized that exam was just too inconsistent. So they replaced it with a widespread pain index and a symptom severity questionnaire.
Yep.
And today, it affects an estimated 2 to 4% of the population, mostly women.
And current research points to the mechanism being central sensitization, meaning this isn't an issue in the peripheral tissues at all. It's an issue in the spinal cord and the brain.
So we're talking about like the volume knob on pain signals being jammed in the maximum position.
Exactly how it functions mechanically. Glial cells in the central nervous system become overly reactive, and neurotransmitters like substance P just flood the synapses.
Oh, wow.
Yeah, the NMDA receptors in the spinal cord basically get stuck in an open position. So perfectly innocuous sensory signals, like a light touch or mild pressure, they are amplified into agonizing pain by the time they reach the brain's processing centers.
That sounds awful.
It is. There isn't a single damaged muscle fiber to point to, but the neurological pain is devastating.
Which brings us to the shifting definitions of pain itself. In 2020, the International Association for the Study of Pain, or IASP, they revised their formal definition.
A very important revision.
They explicitly widened it so that pain reported by people who cannot verbalize it, like infants or patients with advanced dementia, is formally recognized as real pain.
Yes, and the IASP recognizes 3 major mechanistic categories of pain.
Okay, what are they?
First, nociceptive pain, which is driven by actual tissue damage, like a burn or a fracture.
Right.
Second is neuropathic pain, driven by a damaged nervous system relaying false alarms. Think of trigeminal neuralgia for that one.
Okay.
And the third is nociplastic pain, which was a category formally added in 2017. This covers hypersensitive systems with no detectable tissue or nerve damage at all, like fibromyalgia.
But here's the crazy part. A single suffix, algia, is still actively used to name conditions from all 3 of those radically different categories. It completely blurs the lines of diagnosis. You're handed one blanket word that obscures the vastly different biological mechanisms happening in your body.
And that lack of a built-in mechanism has created decades of real-world suffering and intense medical controversy.
Because it's hard to prove.
Exactly. When a diagnosis just means pain and offers no visible proof, like no broken bone on an X-ray, no glaring red inflammation, patients historically faced immense skepticism.
Because if the doctor can't see the lesion, the default assumption for decades was just to label the patient as psychosomatic, like it was all in their head.
Right, and a prime example of this legitimacy fight is vulvodynia.
Okay.
It's characterized by chronic vulvar pain with no identifiable infectious or structural cause. And because it utilized the mysterious Dynia suffix and lacked a visible mechanism, patients were routinely dismissed.
Just told there was nothing wrong with them.
Pretty much. They had to fight for basic medical validity. The National Vulvodynia Association was actually founded in 1994 specifically to push back against this institutional dismissal.
And the epidemiological data vindicated them completely, right?
Totally.
A landmark 2003 study by Dr. Bernard Harlow proved that somewhere between 8 and 16% of women experience this pain at some point in their lives.
It's a huge number.
It is. That data forced a shift in the medical consensus, proving once and for all that no visible lesion does not equal not real.
It was a vital battle for symptom validation. But, there is a secondary clinical danger inherent in these vague terms.
What's that?
If the name cannot prove the cause, evaluating the efficacy or the toxicity of a treatment becomes incredibly difficult.
So what does this all mean for pharmaceutical trials? Like if a patient develops pain while taking a drug, how do doctors know if the drug is actually the culprit?
It's tricky, and the clinical debate around statins provides probably the clearest window into this problem.
Okay, statins, the cholesterol-lowering drugs.
Right. They're widely prescribed, and between 5 and 10% of patients report statin-associated myalgia, muscle pain.
5 to 10% is a lot of people.
It is, and the pain is significant enough that a large cohort of patients abandon these life-saving medications just to find relief.
Literally millions of people stopping heart medication because of myalgia.
Exactly. But researchers decided to run rigorous, blinded, N-of-1 re-challenge studies.
No, I don't know.
A patient takes the actual statin for a set period, then they switch to a placebo for a period without knowing which is which.
Okay, so it's a blind test on themselves.
Yes. And when you unblind the data, the true rate of drug-caused myalgia just plummets. In many of these trials, the rate of muscle pain on the statin is statistically indistinguishable from the rate of pain on the sugar pill.
Wait. If the re-challenge study shows the drug isn't biochemically causing the muscle pain, the only variable left is the patient's own mind.
Yep.
Are we talking about a reverse placebo effect here?
We are. It is a textbook case of the nocebo effect, and the mechanism behind it is entirely physical.
Really?
Physical, yeah. When a patient expects a medication to cause a symptom based on reading a warning label, the prefrontal cortex anticipates harm. And this triggers a specific neurochemical pathway involving cholecystokin, or CCK, which actively amplifies pain signaling in the nervous system. The brain is literally generating the pain it expects to feel.
The symptom is completely real, but the trigger is expectation, not the statin.
Precisely.
The problem is the word myalgia fails both the doctor and the patient because it cannot distinguish between pain caused by the lipid-lowering mechanism of the drug, pain generated by the CCK pathways of the nocebo effect, or pain that is just purely coincidental from aging.
It is a completely blind label.
It is. Although our sources do highlight one fascinating historical counterexample where the vague word actually outlived the mystery, epidemic pleurodenia, commonly known as Bornholm disease.
Yes. First thoroughly described by a Danish physician, Ejnar Sylvest, in the early 1930s.
Right. He observed clusters of people on the Danish island of Bornholm being struck by sudden vice-like chest pain. They nicknamed it the devil's grip because it felt like an invisible hand was just crushing their ribs. The medical establishment classified it with the Dynia suffix pleurotenia, signaling a mystery pain in the pleural cavity.
But today that mystery is entirely solved.
Right.
We know the exact pathological mechanism. It is an infection caused by the Coxsackie virus B.
But they still officially call it pleurodenia.
They do.
Sometimes tradition just wins out, and a 17th century naming convention survives intact even when modern virology has handed us the actual answer.
The inertia of medical terminology is incredibly powerful. We have tracked this linguistic architecture from 17th century Swiss mercenaries suffering from nostalgia all the way to modern pharmaceutical trials battling the nocebo effect.
And synthesizing the scale of this issue today is staggering. The CDC reports that roughly 1 in 5 U.S. adults experience chronic pain. That means these ancient Greek suffixes are doing immense structural work in our modern healthcare apparatus. They aren't just history. They are hardwired into the ICD-10 and ICD-11. Those are the master international coding systems that hospitals use to bill your insurance today.
Yep.
They were heavily utilized in the adverse event reporting for the COVID-19 vaccine trials. We rely on them constantly.
The medical establishment is actively attempting to outgrow them.
We saw this with Silas Weir Mitchell during the American Civil War. He was treating soldiers with devastating nerve injuries from musket fire, and he documented a horrific burning pain.
Right.
He coined the term causalgia, combining causes for burning and algos for pain. It was an incredibly precise clinical description that lasted 130 years.
Wow.
But in 1994, the IASP officially retired causalgia and replaced it with complex regional pain syndrome, or CRPS.
Oh, okay.
A mechanism-neutral name that attempts to reflect a modern understanding of a malfunctioning nervous system rather than just describing the sensation.
This raises an important question, though. The source material highlights this push toward newer mechanism-based vocabulary. We see terms like nociception, which is derived from the Latin for harm, which focuses on the biological transmission of threat signals.
Right.
Or terms like allodynia, which repurposes that old Odine root to describe the mechanical failure of experiencing pain from a stimulus that shouldn't be painful at all, like clothing touching sunburned skin.
Yeah, that makes sense.
But if the medical establishment eventually succeeds in retiring all these old Algia and Dynia terms in favor of purely mechanical biological words, what do we lose?
By prioritizing the mechanism over the sensation.
Exactly. By erasing the ancient Greek root for the actual subjective experience of pain from the diagnosis, do we risk losing sight of the patient's human suffering in our quest for a purely mechanical explanation?
That is a heavy and vital thought to end on. Because ultimately, a patient doesn't walk into a clinic complaining about nociception.
No, they don't.
They walk in because they're hurting. Next time you are looking at your own medical chart or an after-visit summary, or even just skimming the side effects on a bottle of pills, look a little closer at the words. Keep questioning the terminology that shapes our world, because as we've seen, that seemingly objective, bulletproof diagnosis on your chart might just be a muddy linguistic accident from 300 years ago.